So I'm going to hand over to Dr. Halscott, who's going to run through the evidence behind COVID-19 management in pregnancy, and then we'll answer any questions at the end of the presentation. So Dr. Halscott, please let me hand over to you.
Thank you very much. And yes, I've got a number of slides to go through. I sometimes speak quickly, so I'm happy to answer any questions at the end, but I'll try and focus on some treatment, algorithms and whatnot, especially for moderate, severe, and critical illness. So we talked a little bit about some of the therapies and some of the therapies we're using in the United States for mild to moderate, so any outpatient disease not needing oxygen. So the monoclonal antibodies or the polyclonal mixture of antibodies, those are still completely feasible in pregnancy as needed as well. So pregnancy in and of itself, not a contraindication to those. So if they are available to your patients that otherwise would be able to be on home quarantine or able to receive these are options for pregnant patients, and we can reassure them as well. There's not a tremendous amount of data for these in pregnancy. However, there's no evidence that will cause harm as well. As we talked about, and I certainly concur with my colleague. Sorry, the use of steroids has been shown to have a significant survival benefit for recovery trial and some other trials as well. So certainly we support that use. And I approach these patients, whether it's a 60-year-old male in the ICU that I'm attending or a 20-year-old pregnant female, from a similar standpoint in the steroid treatment. And I typically place the patients on 6 milligrams of dexamethasone daily until hospital discharge at this point in time. Initially, in the beginning of the pandemic, we were doing a completion of a 10-day course as an outpatient occasionally, but some of these patients were requiring an entire extended 10-day stay in the hospital. Either or, I think it's finding it's more important they get treated with steroids appropriately in accordance with the trial data. And specifically in pregnancy, some practitioners using hydrocortisone and methylprednisone due to those concerns I mentioned earlier regarding a potential in some of the older studies with recurrent weekly dosing of steroids and some fetal growth concerns. However, those growth concerns are mitigated after birth and those babies catch up in growth. So it's a different dosing, a different situation, different concern. So I wouldn't let that influence the decision to give steroids for a pregnant patient for COVID. I would absolutely give steroids. Just forest plots looking at the benefits. I think we're all very familiar with this, and for time purposes, I won't belabor it, but steroids work. That's the long and short of it, and we should give it to our patients pregnant or not. It's showing for other outcomes for mechanical ventilation, if they'll need vasopressors, and symptom relief as well, and all showing a benefit. Of note, when we initially put some of these guidelines together, we had less information on the IL-6 receptor antagonizing antibodies, tocilizumab. That data has become more robust throughout the pandemic, throughout the multiple waves we've had, and we're utilizing this in our hospitalized patients as well, and seeing some benefit and seeing potential decreased risk for mechanical ventilation need and a reduced length of stay for the hospital overall as well. Again, safety data is not tremendously robust for some of these medications because they're newer. However, for these classes of medications, we do have a lot of data that shows that they are safe in pregnancy. And certainly, if it can help protect the mother, that will protect the fetus and the neonate as well. Some of the other medications that have been offered and that have been utilized, I presume, in India as they have been in the United States, remdesivir and some of the HIV medications, hydroxychloroquine or chloroquine, azithromycin, interferon, and ivermectin. Some of these have had some data that there may be some benefit in some population, others have had no data, and some have had evidence of potential harm with no benefit. But a significant survival or mechanical ventilation benefit hasn't been shown in any population with these medications. And so, as this next slide shows with a recent infographic from the World Health Organization on which medications should be utilized for which level of disease. And so this is directly from the WHO's website that I pulled off a few days ago. So this is up-to-date, evidence-based, and we can see, as we discussed, corticosteroids are recommended for severe and critical disease. And IL-6 receptor blockers, the tocilizumab, also for severe and critical disease. And the other medications, there's not a significant benefit that's been shown with those. So those probably should not be utilized for our pregnant or non-pregnant patients, or only utilized in a trial setting. I won't belabor this algorithm. This is the algorithm that Dr. Jason Vaught, my colleague here, and I constructed for the Society for Maternal Fetal Medicine, which is the predominantly United States governing body, but an international governing body dealing with high-risk pregnancies and these sort of complications. So this is a algorithm utilized to triage patients in presentation with COVID and how to help them move through the medical workflow in the United States. And the reference there is has the entire algorithm and has it explained how to utilize it as well. Very briefly, at the beginning of the algorithm, a patient presents to the hospital and then we evaluate, do they need supplemental oxygen? Are they hypotensive? What are our interventions that we need to do at this point in time to resuscitate the mother, to support not only her, but to support the ongoing pregnancy? And then we tried to make it as simple as possible, kind of a quick yes, no to any of those questions. If a patient is otherwise doing well, only symptomatic, not requiring oxygen, then that patient's pretty stable and can be managed as is. If any of those things are not true, then we recommend an escalation to consultation with an intensive care specialist, critical care specialist, and having that extra insight to delineate where this patient needs to be triaged to, where they may need to be transferred to. And again, I would not change that based on pregnancy, except for if there's a pregnancy issue as well, having this patient in a hospital or facility that has obstetrical services to aid as needed for that additional potential medical need. I think this is something very important that we see in pregnancy a lot, but outside of pregnancy can be different, is that the normal pregnancy state for an arterial blood gas, which a lot of times obviously we're getting for our COVID patients, normal pregnancy is a compensated respiratory alkalosis. So a normal pregnant patient should not have a normal PCO2, okay? If their PCO2 is in the normal range, that is concerning, especially in a patient with a respiratory illness. And it makes us concerned that they may be retaining CO2, they may have impending respiratory failure. And those are patients that we need to be cognizant of what other additional supplemental oxygen, and may we need to intubate and mechanically ventilate these patients. So vitally important for the obstetricians in the audience to remember to relay this to our non-obstetrician colleagues. As an intensivist myself, a lot of my intensivist colleagues who are not also obstetricians, this is not at the forefront of their mind. This is not the patients they take care of most of the time. So helping them remember that when they see a pregnant patient, that a normal arterial blood gas is not normal in pregnancy, can be vitally important to recognize which patients are sick and which patients need intervention. The supplemental oxygen strategies, I think we're all very familiar with. All of them can be available in pregnancy, escalate as needed. Our goal in pregnancy, as we stated, is oxygen saturation greater than 95% by capillary pulse oximetry. This is looking at prone positioning, which we utilize in the non-pregnant patients, especially for COVID and ARDS, acute respiratory distress syndrome. Can definitely be done in pregnancy. This is from our colleagues in Baylor University in Houston, Texas, and they have an excellent paper with these pictures and descriptions of how they've had prone pregnant patients for COVID or for other respiratory concerns. There's videos attached to that reference as well, so that can help a team develop not only an understanding of the safety of proning a pregnant patient, but that if it's needed, certainly it should be done and how to accomplish that. This is from an additional update to the Society for Maternal Fetal Medicine guidelines that we placed, and there will be a forthcoming update that we're doing as well in the next few weeks to month or so. But this was looking at refractory hypoxemia. So a patient in the ICU, almost always intubated, who we can't optimize their ventilation, even with prone positioning, even with appropriate ventilatory maneuvers, and they're still having significant ARDS or significantly low partial pressure of oxygen. What are the mechanisms we can use to help improve that for the patient? And this is not influenced by pregnancy until you get to the end. So we would recommend all the same interventions that we would do for a non-pregnant patient for a pregnant patient who has refractory hypoxemia. Attempting prone positioning. A patient can be prone, typically in the United States, we'll do anywhere from 12, 16, even 18 hours, depending on which trial and which data you're looking at. Those are okay in pregnancy as well. Setting up the fetal monitoring and positioning that appropriately, utilizing ultrasound to help determine where to place the monitoring probe can be helpful, but it's not a contraindication that a pregnant patient can't be monitored while she's prone. The other options we can add for refractory hypoxemia, the inhaled pulmonary vasodilators, nitric oxide or evoprostenol, also safe in pregnancy. They're metabolized extremely quickly, and there's not really even evidence that they're able to be metabolized and cross the placenta, that they're metabolized prior to reaching that part of the circulation. If a patient who's been treated appropriately for refractory hypoxemia has had optimization of the ventilator or optimization of inhaled pulmonary vasodilators, as well as use of neuromuscular blockade as needed, they still haven't been improving. We looked at the data to say what is a good point to consider discussion for delivery, not necessarily to deliver at this gestational age, but to say at what gestational age do we start to have a diminishing return of benefit for ongoing pregnancy for the fetus. And most of the data points to about 32 weeks being that level. And so when we made this algorithm and discussed this, we had at 32 weeks to be a break point to then say, can we continue this pregnancy? Do we need to continue this pregnancy, or will delivery change any of this management for the patient, and how ECMO, extracorporeal membrane oxygenation, may play into that? Again, I want to stress, not saying 32 weeks for a critically ill COVID pregnant patient is an indication for delivery. And I want to make sure that's precisely clear. However, after 32 weeks, there has to be a conversation about, is an ongoing pregnancy beneficial or not for mother and or for fetus. If someone could mute, please, thank you. For neuromuscular blockade, certainly can use this in pregnancy as well, and I would recommend utilizing this in pregnancy. We have had pregnant patients that we've utilized this for to help optimize ventilation. Obviously, these patients need to be sedated as well. Again, the typical agents that you would use, propofol, dexmedetomidine, will utilize a lot in the United States. Other things that are less common but can be utilized, ketamine, higher dose narcotics, benzodiazepines, are all okay in pregnancy. Our optimization of ventilation is the primary goal, and we need to accomplish that. The paralytics that we're typically using, cisatracurium, rocuronium, and vecuronium, those can be continuous or intermittent depending on what the resources are, but ensuring that you have an adequate dose and the patient is being ventilated efficiently is the goal, and making sure we typically use a twitch monitor and utilizing that as well, or however measure of blockade locally should be utilized. Important thing to remember, and this will be in the new revision that we're working on, is that being mindful with heavy sedation, being mindful with paralytics, those do cross the placenta to some degree. So things like a biophysical profile are not going to be valid while the patient is on heavy sedation and receiving paralytics. Fetal heart rate variability may be decreased as well, especially with things like narcotics, as we know. So interpreting a fetal monitoring or continuous fetal monitoring or some other assessment of fetal well-being may be challenging for these patients. And that may factor into not only our concern for the patient and the fetus, but also our colleague taking care of them in the critical care setting, and having those conversations in addition to some of the other maternal physiology of pregnancy conversations is vitally important for these. Some quick Ecmo schematics. I think most of us are familiar with some of these, especially my colleagues who perform Ecmo. None of these placements are contraindicated by pregnancy. The issue with a gravid uterus is you may have more challenging flow and stoppages from that standpoint. So bearing that in mind with cannulation and potentially moving cannulation sites as needed, but pregnancy in and of itself is not a reason not to give a patient Ecmo who otherwise needs it. And also, ECMO is not necessarily an indication for delivery to accomplish ECMO. It's a complex interplay of where we are in the pregnancy and what may or may not be most beneficial for the patient. The ELSO criteria we utilize as well for our ECMO indications. I presume it's similar with my colleagues. The vast majority of these patients are for prolonged ventilation, hypercapnia, hypoxic respiratory failure, those sort of issues from a COVID standpoint. But some of these patients will have the cardiac findings associated with COVID and also need VA ECMO as well. As far as delivery timing, for mild to moderate disease, we don't recommend really any change from usual obstetrical concerns. So these patients, if they're acutely positive, obviously should be in an isolated area. And as was discussed, moving them to a ward where they can be kept separate from other patients to decrease risk of spread, and also PPE for the providers to decrease risk to us and to our colleagues, so we can care for not only them, but all the other patients we'll need to. But from an obstetrical standpoint, it doesn't affect our timing of delivery, doesn't affect our mode of delivery. For severe and critical disease, it can be a little bit more challenging. And I think having a multidisciplinary discussion with all the providers that are taking care of these patients becomes very important to understand what are the risks and benefits to delivery at any particular gestational age, or a particular mode of delivery, or particular setting for delivery. So I would say these should not be hard and fast thresholds. These should be discussions regarding what may or may not occur based on a delivery, but also being cognizant that significant systemic illnesses increase the risk of preterm birth. So these patients may go into preterm labor on their own. It approximately doubles the background rate of preterm birth, which in the US is around 10%. With, as discussed previously, neonatal mortality is very low at 32 weeks, and it stays about that level. It doesn't get any better significantly after that for the most part. And the morbidity is pretty low as well. So just under 9% at 32 weeks, and then drops in half thereafter and stays low throughout the rest of the pregnancy. So that's why we utilize 32 weeks as a time to have a discussion about what an ongoing pregnancy may look like and what other interventions may still be on the table for a patient. Again, not to say deliver at 32 weeks, but to say 32 weeks is a good milestone to aim for if safe, and then have a discussion about what delivery will look like and where and when that may occur. The prophylaxis we talked about, there's not great guidance, I feel like, in any population for this. At this point in time, there's some evidence that full anticoagulation may be more beneficial from a decreased risk for ventilation, decreased risk for hospital stay. I think utilizing that data and extrapolating to pregnant patients is not unreasonable, but having a discussion about the risks and benefits, because our patients will have other interventions other populations may not have, like regional anesthesia. They will all have a bleeding event with a delivery, even with a vaginal delivery, and approximately half a liter blood loss as an average. In the best, most rigorous studies, C-section up to a liter blood loss, and that certainly can be increased with full anticoagulation. So being mindful of those risks and being prepared for them is very important. And then lastly, certainly concur with my colleagues, vaccination is safe, effective, and I would stress an extremely important aspect for personal health care for the patient, as well as public health for the population in general. There is absolutely no reason not to get vaccinated from a pregnancy standpoint, from an attempting to conceive standpoint, or from a breastfeeding standpoint. I would recommend vaccination for all, regardless of any of those statuses. And I think that can help not only protect the pregnant patients while they're pregnant, can protect the fetus. There is evidence of transmission across the placenta of antibodies, and there's also evidence of transmission through breastfeeding of antibodies. And thank you to my colleague for her contribution to those studies as well. So we strongly, strongly recommend vaccination broadly and widely. Thank you all. I certainly appreciate the time. Hope I was able to accomplish that quickly. Feel free to email me at that email address, and I'm happy to answer any questions.
Thank you so much, Tori. If you can stop screen sharing. We are 1 minute before time. I just want to say thank you so much for the great turnout that we've had today. It's really heartwarming to see over 200 of you joining us in this conversation. Dr. Sharma, I'm going to ask you to put your questions in the chat. And Tori, there's a question around enoxaparin in the chat as well. But I do need to wrap up since we're at time, and we'll be recording this and sending this out. So put questions in the chat. The next sessions are going to be on palliative care considerations in COVID-19, the rational use of oxygen. We're going to have a very important session October 14th about resilience, and it feels late to have this conversation because everybody here has been working for the last year and a half with full speed and no breaks. And at the end of October, we're going to focus on COVID-19 diagnostics and really integrated surveillance for pandemic response. Our next sessions are going to be hosted by Rajiv Gandhi Government Hospital in Chennai. So that's a new host for us. Welcome. Thank you for joining us. And then for all of you that are here, so all 200 people, I know that your institutions or your health facilities, your needs are very different, very independent. And the RISE project team is here to support you, right? So in addition to this webinar, which is national, most health facilities, please mute yourself. Most health facilities are doing at facility trainings. We're using a hub and spokes model where the hub facility is doing 3 to 4 day trainings and inviting neighboring hospitals to participate. Your contact details are on the screen, and so I'm staying here a bit longer. So Dr. Nochiketa Mohanty, Dr. Surendra Sharma, Dr. Bijoli Sinha, and Jen Daniels, and they are available on WhatsApp, email. They are there to coordinate and champion each of the facilities to get whatever they need in terms of clinical TA. In addition to in-facility workshops led by experts, we are looking at innovative ways to bring just-in-time learning to where you're at. So we're still learning. This virus is a tricky one, but thank you to everybody who are there championing moms who are just, it's the most scary time when you're pregnant and you're also COVID positive. So for those of you who are able to advocate for mothers, for them to have a safe and kind experience during labor and delivery and through the whole antenatal period, thank you very much for everything that you're doing. So we're going to stop there. I see the chat is exploding. So let me just quickly screen. Thank you for reminding everybody to complete the post task. And Dr. Hal Scott, thank you for your responses. And Dr. Jane and Dr. Verma, 270 patients a day. I've never heard of those numbers. So I'm very impressed that you were able to take time out today to talk to us.
Thank you so much.
Any parting words from our speakers?
Thank you, Bhakti. Thank you all of you who have joined for this webinar today.
Yeah, we're very grateful. It was such an opportunity that we could share our views. Thank you, Bhakti. Thank you, Vijali. And thank you, everybody, for giving us this opportunity.
Take care, everybody. Stay safe.
Thank you all.